Hello, hello. It's Alan Wiederhold, your host of Neuma, the Crossroad of Science and Enlightenment. And I have two very good, I would call friends now. I think we're at that level now, Nick, Amil. So
100%.
I have Amil, Patel, and Nick Nowak from Meeko Health joining me in the studio today. And this actually is really perfect timing because we're coming right off of the heels of the last episode that I did with Doc Askins when we talked about ketamine and what it is. So this is going to be really great for me today because we're going to look at this from a different side. For me, it's the side that I really kind of spent most of my career in, and that's the employee benefit side. So before we do, though, let's introduce you. So Amil, tell me, how did you come up with this idea? Because I remember when you and I, when we met several months ago, you kind of shared your story, and that really resonated with me because of my story. And then Nick, I want to hear yours after that.
Yeah. Thanks, Alan. I mean, my journey to this idea was not too different from, I think, many folks out there that end up having some sort of firsthand experience with psychedelic therapy. I was going through my own mental health issues right around COVID, and found myself kind of trapped in the traditional construct of mental health, and just feeling super frustrated and disappointed that, I mean, myself as a pharmacist, as someone that kind of deeply understands and empathizes with what people experience in healthcare, going through the mental health system, firsthand experience myself during COVID just led me to this deep sense of frustration and this cycle of like feeling even more lonely and frustrated because like nothing was working, and everyone was telling me like, this is all you've got, this is all you've got. And that led me to, it was a long story here, but I'll shorten it. It led me to MDMA therapy, which like there's no way to cut it. Just radically changed my life. And it was after that first MDMA therapy session where I started chatting with some close friends that I think there's an opportunity here to kind of make a difference at scale in people's lives, and that's when we came up with the idea of the company.
I'm thinking about an article that Healing Maps actually just put out like a week ago, Friday, and I was quoted in there. In I think there was a tweet or something a few weeks before about executives and business owners who basically, I always use the term, blow up their lives, and they leave the companies that they start or found when they go through therapy, because you just have this, like, you have a completely different lens and you go back and you want to create or give something back in a way that you hadn't before. So is that about kind of what you're
100%. Yeah, I mean, 100%. I don't know. I think no matter the person that goes through the experience, um, I think for me, the outcome was, wow, I wanted to take radical responsibility, and what can I do to push this forward? I think, not everyone has that outcome of a psychedelic assisted psychotherapy experience. However, I would say on the margin, I think, most people that go through a structured psychedelic assisted psychotherapy experience, you just have this restructuring of priorities of like what's important to you, and that just is kind of exposed, and it's there. You see it. It's so clear, and it kind of it kind of allows you to just get in touch with what's most important to you, and I think like that's one of the gifts of psychedelic assisted psychotherapy.
So it's almost like, the way that I always put it is that I think as an entrepreneur, you always have this chase everything that you think really what the world tells you matters, like the have it all lifestyle, so to speak. And then you go through therapy and it's almost like it's the have what matters lifestyle that you're chasing, because you find that your priorities are, at least for me, are a lot different than where they were. Nick, I always joke with you, the person that I was 3 years ago, I feel like I'm almost unrecognizable, even to myself. I mean, people who knew me, all I cared about was winning. Like everything that I had to do, I was a narcissist. I would always tell you how great I was, and that was out of fear. So yeah, I think that was one of the biggest things that was very similar to me, opening up and then just being able to open my heart and to be able to tell people really what was going on. So
Which, Alan, I still, based on the stories you share with me, I just refuse to believe that Alan ever existed.
yeah, well, I have an older son who will who will tell you he'll tell you the truth. And I think we did an episode of our podcast and we talked about that and how work was so much more important to me. It defined everything that I was and who I was. I was very uncomfortable in a conversation with people at a party or anything else because I just equated my identity to success and to all of this stuff. But what I realized in my first MDMA session, I actually relived a conversation more like a really, really bad fight between my mom and my dad. I was 4 and I never remembered this, but it came up in my session. But it defined everything that I thought about success because it was a financial fight about money with when you're 20 and 21. My parents got married very, very young. It shaped everything. And I didn't even know that, which is what was so crazy. So, then talking to Matt Zeman, you know, you keep moving the goalpost, which is ultimately what happens with success as you're chasing it. It's just this like, well, I accomplished that. Now what? I accomplished that. Now what? And then you have to come back and you're like, wow, give myself some grace for what I've actually accomplished rather than having to go accomplish more. It's being able to just kind of relish in being able to do that. So, Nick, how did you get to join Emil in this journey?
Oof. Yeah, and so our history here dates back to, what was it, Emil, 2005, freshman year dorms, just these little
Oh
kids
my
from the
gosh,
Midwest.
I love this.
Yeah, I don't know if we shared that history with you, but yeah, really remained like really close friends over the years. My career was more clinically oriented, so firsthand suffering. Spent about 5 years on Travis Air Force Base in California, the mental health suffering on just a daily basis, and the lack of tools available to help people get out of these ruts. I've seen it on the civilian side, I've seen it on the active duty side, and the emerging data and science, which is ultimately our core thesis here, and not even thesis, core outcome focus, is just incredible. When I was in school, so we graduated in 2011, the only education we received, Alan, was symptom management. And you take a drug, you suppress a symptom. Humans are basic creatures, serotonin, you stop it, symptoms come back. And we know that like we're really, really complex human beings. And it's kind of an absurd process we've been doing for 30, 40 plus years. Well, it helps millions, but there's also about up to 60% treatment resistance. And the idea that ketamine, MDMA, psilocybin, these other agents that are coming through the FDA pipeline are able to not have a daily dose and help individuals find the healing that they deserve is just fascinating. Like ketamine's in the body for a few hours and it's gone and it's out, but the effects resonate afterwards, kind of like an antibiotic. And the infection's gone from an antibiotic. And with these medicines, the fact that they keep working is just baffling to me from a pharmacological standpoint.
So
So
from a pharmacological standpoint, how do they work? Because you hear so many people, at least I did in my research, because when my doctor told me, bro, you need to do this because like you're broken in a bad way, so to speak. And I resisted. I said, there's no way I can do this. This is a drug. This is a non-Christian thing. And just say no to drugs. I mean, anybody who grew up in the 80s. But the more that I learned about it, the more that I learned that that was actually not true. And we're okay having a beer, which to me is a drug. Coffee is a drug. SSRIs, drugs, but so are aspirin, so are everything else. But how do these work from a clinical standpoint? Like,
I think Emil has a really interesting point of view I'd like to pass over to him on the actual process here.
I mean, I think depending on the psychedelic compound, they're going to work in slightly different ways. But I think if you're asking the question of like you know what is the effect that is had that contributes to the healing experience, I think the interesting thing about and what we're learning about psychedelic therapy is this ability to be in a dissociative state of mind, and the ability to let down your guard that's naturally there, and the ability to kind of quiet all the armory that exists, all these like protective layers that exist to allow us to kind of get through the day, allows things to surface like Alan, the argument or the disagreement that a younger Alan witnessed between your mom and dad, but it allows these things to surface, and it allows them, it allows the patient or the person an opportunity to kind of look at this without any sort of strings attached, without judgment, without fear,
Hmm.
and just objectively look at these traumatic memories, no matter how small or big, subjective, right? But like looking at painful memories and being able to kind of deepen your understanding of what was going on. How did it impact me? How does that experience show up in my day-to-day life today? And, am I okay with that? How does that impact my relationships with others? How does it
Mm.
impact my relationship with myself? And having a window, an opportunity to be able to do that. I mean, we kind of hear this in the psychedelic space. I don't think often enough, but it is really like hours and hours and hours, if not years of therapy condensed into 4 to 6 hours. And I mean, when I think, and I don't want to jump ahead here, but when I think about, we're early, but the roller coaster's like taken off, and we're still early. But when I think about what this looks like in the future, and I think about that idea of being able to condense years and years of therapy into a 4 to 6 hour session, and the value, and we talk about value, we talk about outcomes, we talk about, efficacy, we talk about durability. These are all buzzwords in the healthcare space, in the payer space, where it's like, okay, we all know where this is going, right? Water acts like water. And so that's what gets us so excited, both as
Hmm.
clinicians, but also as people that think that the future is what we build, it's what we make of it. And so, I think there's just incredible opportunity. I didn't want to jump ahead, but
No,
I
no,
hope
I
I
think
answered your
that
question.
I think it from a couple of different perspectives. I think it's brilliant because I think that was the very first thing that came out of my first 3.5 hour session. So I didn't know all of the things that were buried in my subconscious, and I tell very openly my story with my wife. Like I was not in a very good place, and my wife said, I love you, not in love with you, figure it out. You're not in love with yourself. You haven't been happy in a really long time. And to be able to bring down the ego, and I always think about that the way that you said it, Timothy Leary, with ego death. And just being able to quiet that default mode network, and to be able to, I almost equate it to like watching a movie with popcorn with your trauma, because you are able to sit there and objectively look at what it is, and then kind of like study it and analyze, and to be able to confront it. At least that was for me in my first 3.5 hours. I went back and I relived my abuse. I relived this fight with my parents, but I got to confront it. Like I actually, at the end of all of those, I sat with my abuser. I sat with my dad and I said, "Why did you do this to me? Like, why did you put this on me? I was 4." So you're able to have these almost conflicts without actually having to experience the conflict to be able to come to resolution. But when I came out, that was what my facilitator said, the exact same thing. You just did 10 years of therapy in 3.5 hours. How do you feel? I'm like, holy cow, like liberated for the very first time. Like felt like I could legitimately walk through a wall. It was exactly that. I think it's just being able to look at it objectively without having to think about it. And I work with so many people now. They're, worked with the same psychiatrist or psychologist or whoever. And they're like, for 20 years, I've been just given SSRIs and coping skills. Like, that's
Hmm.
exactly what you were saying.
Hmm.
And they're not working. But the other thing I think that resonated, Emil, is that from an employee benefit standpoint, we look at wellness plans, and we did very earlier on, what's the return on investment? You look at the indirect cost of care. And that's
Hmm.
always how I looked at everything through healthcare. So it's, 40 to 50% of every population in an employer sponsored health plan is borderline chronic, whether that be mental health, whether that be disease states. They're the ticking time bomb ready to happen. We don't even address that in mental health, because I
Hmm.
venture to say that it's probably a lot higher than that because of where we are right now as a society with COVID and everything else.
Hmm.
Hmm.
So why would an employer not think about this as an alternative?
Yeah, I think that's a great question. There's a lot to unpack there. I think employers on the margin, there's habits that have been built in healthcare that I think are make sense when you look at them. There's like these the way that we do things in healthcare, the legacy ways of doing things. It's like I understand why those exist, and I'm hopeful that we can kind of like shake that up a little bit. So ketamine's a great example of legacy. So if I'm an employer, if I'm a health plan, I'm thinking about ketamine. You think about all the value associated with ketamine, but at the end of the day, it's like, we're in this habit of we're going to cover medications based on their FDA approved indication. So that's one reason. Okay. And I think what's interesting is we've seen evidence over the past few years of where we've been able to, as a society, we've been able to go to health plans, we've been able to go to payers and say, look, maybe it's a good idea to cover medications for a non-FDA approved indication. And I always go back to fertility. Fertility, in my mind, is a great example of that, right? Just a quick TLDR on fertility. Fertility benefits have popped. They've popped up across U.S. employers. And the reason you got to ask yourself, well, why do these fertility benefits exist? It's because the incumbent health plans weren't covering fertility. And specifically, they were only covering the fertility processes, the fertility medications, if women had a diagnosis of infertility. But we know that in the culture we are today, we have women in the workforce that are trying to plan ahead, right? They don't have a clinical diagnosis of infertility, but they still need access to those medications so that they can do things like embryo freezing or IUI, IVF down the road. They want to pre-plan their futures, right? It goes back to healthcare and human agency. And so when I think about things like generic ketamine that are kind of quote unquote wanting to be used off-label for mental health, I think this is just a process in working with health plans and payers and educating them. Like, hey, similar to fertility, there's a strong use case here. There's a strong ROI. There's strong outcomes data. And it's educating them so that we can kind of get over that hump of, well, why would we do that, right? It's because it's always a question of why. And I think there's a huge opportunity there, because if you go back in time to fertility benefits and you think of where we are now, well, fertility benefits it's very much driven by employee demand, right? Employees were expecting it, they wanted it. And when I think about what employees want today in mental health, people want really effective mental health options.
Yeah.
So I think this is just ripe for the taking. It's a matter of going out there and shaping public perception. And then I think there's just generally stigma around ketamine, right? That there's incredible stigma around psychedelics. There's incredible stigma around ketamine. And I think, Nick and I as pharmacists, it goes back to education. Medications in general, from a pharmacist lens, medications across the world, and particularly in the United States, our lens is medications are tools, right? And you can use a hammer to build a house. You can use a hammer to hurt your kneecap, right? Like, it's how you use the tool. You want to use the tool with the right intention. You want to use it productively. And I think, I think that just goes back to education and awareness. But I will say, I think the other thing is the other headwind is incentive structures in the healthcare ecosystem, right? You've got, and I mean, this is more of just me kind of ranting on a podium for a second. But I mean, when you think about ketamine and you think about medications like Spravato, I don't know if your audience is going to be familiar with Spravato, but Spravato is a brand name medication approved by Janssen, a pharma company owned by Johnson & Johnson. It was approved in 2019 as a nasal spray for mental health, a nasal spray for treatment-resistant depression. And if you look at Spravato has very high costs, and it is essentially, on the margin, it's essentially generic ketamine. And I think that's so frustrating when you look at that from a pharmacist perspective, because you understand, if you peel back the curtain, you understand all the rebate incentives and all the reasons that brand name medications are patented, are put on formulary. We're directing patients to brand name medications with high copays, high coinsurance, high costs to the plans, premiums increasing year over year, 14% year over year at times. And it's just frustrating because ketamine, again, approved in 1970, working well. and the safety and efficacy data on the margin are head to head, same, right? In fact, there's more evidence to date that the efficacy data on generic ketamine versus inhaled, or intranasal Spravato, it's better. And so that's just, that's just frustrating. But the tide is turning, right? We're seeing large payer system. We're seeing the VA offer ketamine for mental health. We're seeing major health plans like Kaiser offering ketamine for mental health, not Spravato, but ketamine. And so the tide's already shifting. It's just a matter of like, how can we accelerate?
So let's talk about that for a second. Actually, there's a couple of things I want to talk about. So ketamine itself, the first thing that I think of immediately is Matthew Perry. And then there are different kinds of ketamine, right? There's the IV that I can put into my arm. There's an intramuscular, and then is there a pill? I mean, what forms does ketamine come in? I see commercials for these at-home companies. I'm sure it comes in a lot of different ways, correct? I mean, clinical, ceremonial. How does ketamine actually work?
Yeah, so ketamine from a delivery standpoint. So Meeko's only focused on in-clinic ketamine. There
Okay.
are some at-home ketamine uses. So in-clinic will generally be intravenous. So you get 100% absorption as opposed to intranasal, which is roughly 40%.
Right.
Other routes at home may be like a troche, which is like a sublingual lozenge, which has lower absorption as well. And as Amil touched on too, and you as well, Alan, it's always like set and setting and safety. So from a ketamine standpoint, I've probably given ketamine like thousands of times. I have no idea. Like so many of those were like asthmatic children in the emergency department. Like it's used. We've been using it since the 70s, and we know how long it's in the body. We know what type of adverse effects there are, and we have a really good idea when it's in a safe clinical setting, and we're able to do appropriate monitoring. So in our case, from a mental health standpoint, we are giving a sub-anesthetic dose, so it is a lower dose than I'd give to a really vulnerable
patient.
child. Yeah, a really vulnerable child. They'd actually get a higher dose than the mental health patients. And then in our case, like the IV ketamine, it's FDA approved, it's manufactured, but it is an off-label indication. The nuance here, troches would be compounded, so they are not FDA approved, and it'd also be an off-label indication and not an FDA approved route of administration either. So a little bit in the weeds there, but I think it's important to highlight.
And I think it's helpful because I think you hit it. I think one of the biggest differences, at least from the conversations I've had with people when they ask what I do, and I say psychedelic facilitator, that you want to talk about getting a group of people together in a room to start sharing all of their stuff, tell them what you do. But that's like the first correction I always tell people is, well, Matthew Perry, unfortunately that happened. But in my mind, I don't think it was ketamine that killed Matthew Perry. It was Matthew Perry was constantly looking for the next high. He was looking for the next escape, and he did it at home in a very irresponsible way. So we're talking about what Meeko does is a very responsible in clinic, in an actual setting. There is a process. And then, like we talk about with any of this, it's always the intention, the set, and the setting, and then the integration behind it. Correct?
Absolutely. I think something else to highlight here, Alan, is obviously Matthew Perry, like so unfortunate for any human being with that suffering. Ketamine actually has really great data for specifically alcohol use disorder and opiate use disorder. And so for those clinics, they'll do screening for those patients, be really selective in those settings. And then, in clinic and have a continuity of care model for follow-up. And it comes back to that agency, being able to dive inward, find out what that underlying root cause mental health struggle someone may be having in order to help break that cycle.
So when we look at health plans, and I've been looking at them for 30 years, the top 10 things that we really see right now, a couple of things. So right now, I always draw a pie chart for a self-funded employer because it doesn't matter whether you're fully insured or self-funded. It's just who pays your money and how bad do you get screwed by having the insurance company keeping it all. So when you look at the pie chart and you look at how claims and admin and fixed cost and indirect cost, if you're looking at that, over the next 5 years, 40% of an employer's plan spend, their just medical claims cost is going to be RX. And Amelia, you actually had said something that I wanted to hit on. You were talking about how formularies and these rebates and all of these things work. Do you want to maybe go into that a little bit and really kind of explain to me how does that work? So a drug that might be on a list might actually have some money coming back. Is that true?
Unfortunately, yes. Uh, uh, you know, if you think about what is a formulary is think of a formulary as a menu at a restaurant, right? And there's different sections in the menu that are going to have, your like different levels of pricing, right? And the goal of a health plan is to work with their pharmacy benefit manager in structuring a formulary that ideally drives certain behaviors. And the behaviors that you're looking to drive are typically you're looking to drive behavior towards generic drugs. Or if there's a brand name drug that just has stellar outcomes compared to a generic alternative, then you might allow the brand name drug to be on formulary. Right? But the goal at the end of the day of a health plan is really you want to steer prescribing behavior and member behavior so that people are focused on value. That's what you're trying to do. And so you come up with a drug formulary, a list of medications, and you have different tiers on the formulary, right? So you have different tiers on the formulary. You might have a tier 1, tier 2, tier 3, and these tiers are going to have a different copay or cost sharing structure for you, the member. And again, the goal here is like, hey, if we set tier 1 drugs at a $0 copay, then hopefully more people are going to go and ask their doctor or work with their doctor in prescribing tier 1 medications because those are generic and those are going to have a lower cost incurred to the plan. Then you're going to have a tier 2, tier 3, high cost specialty medications, right?
And I think
tiers escalate.
I think we're even seeing tier 4s and tier 5s now. I mean, I think that's where we are.
Where we'll get creative, right? And I think what we've seen over the years is there's this. I mean, there are so many games that are played in terms of cost sharing. I don't know if you really want to call it cost sharing or cost arm wrestling, I might call it, between members and payers. And oftentimes you'll see brand name prescriptions will be, brand name prescriptions or brand name medications. Pharma companies behind those medications want to incentivize placement on a formulary such that it increases the chances that prescribers and members will go ahead and get access to it. And so pharma will play a few games. Pharma wants to make sure that they're appeasing both payers and members, right? So what pharmas will do, and I think, Alan, you'll have borne witness to this firsthand, but pharma companies will incentivize payers to optimize formulary placement by offering a rebate that comes on the back end, right? So the rebate, and oftentimes volume-based rebates, the more prescriptions flow through of this medication, at the end of the year, the higher your rebate check is going back to the plan. And these rebate checks are so large that oftentimes, like CFOs of health plans they're forecasting that into their model, right? These are massive rebate check. And the other things that pharma companies, so that appeases the health plan for prime tier placement to try and drive prescribing habits or access to that medication. Now, on the consumer side or on the member side, pharma companies will offer these copay assistance programs, right? So oftentimes, pharma's playing both angles, right? It's like, hey, we're a brand name medication. We get it. Please don't place us on the tier 5 formulary where it's going to be a $500 copay. We'll give you a really huge rebate. Try and place us on the tier 3 of the formulary, which is like brand name medications, right? Where the copay is going to be $100. All right. And we'll give you a huge rebate on the back end. Health plan says, okay, thumbs up. Now the pharma company is they're looking at their next battle, which is, okay, it's $100 copay. Well, that's a blocker. How do we remove that? Here comes copay assistance programs, right? And so they're playing both sides of the field. But at the end of the day, the list price of the medication, and just kind of why we see the list to net bubble growing, list price of medication increases year over year because of this like dynamic where pharma's kind of playing both sides, and they're willing to go deep on both sides, increase rebates, increase copay assistance. And the reason they're able to do that is because they increase the ceiling cost of the drug. And so it's just a perverse game that's being played. And we're seeing, and I want to just really quickly, Alan, I want to tie that back for your audience to like, it is important to understand that game that's being played, especially, I mean, personally for me, because we're about to see that go gangbusters with this opening of the pipeline of FDA approved psychedelic medications, we're seeing the issues firsthand of that dynamic come into play with Spravato versus generic ketamine, right? And the frustrations that exist from clinicians like Nick and I, where ketamine is just very, very cheap generic drug and Spravato is this extraordinarily high cost brand name medication that can cost a plan upwards of $50K a year. And I want to make sure that, when we think about health plans who are thinking of forward looking, thinking about the future, thinking about mental health parity act requirements that they're going to need to abide by, and we're thinking about the games that are being played by pharma companies, psychedelic pharma companies. We want to make sure that we're pushing back. We want to make sure that we're focused on, in health plans in particular, payers in particular, focus on value. Let's focus on value, focused on low cost, high durable outcomes. And I think, if we can continue to point or to put a spotlight on that, we'll make more progress faster.
I was actually going to give another example of kind of how that works for people who are beyond psychedelics. And I think we just saw it. I mean, if you look at Humira, it's probably the greatest example of what we've seen probably in the last maybe 10 years. So AbbVie, the cost of Humira was somewhere around $11,000 to $14,000 a month. But there was a $3,300 rebate. We were actually in my healthcare plan days, we were actually sending people to the Cayman Islands for the exact same drug for $3,500. $3,500 for the same drug that in the US is $14,000 with a $3,000 rebate. It makes no sense. So, and then you see these copay programs and these employers like, well, I get the first 2 months of my whatever for free. It's not free. It's $25,000 is what they're giving you to keep you on it all year. So we used to sit down with our employers and it was almost the same education to be able to explain right now, here's your cost. But if we make this tweak and we do a little bit of medical tourism and you just have the members go there. And I think one of the coolest things about one of the only things that came out of COVID was the expansion of the CARES Act. So because now through the expansion of telehealth, they didn't even have to travel there anymore. They just did a video consult and the drugs just showed up at their home in a temperature controlled box for 70% less. So it is the exact same thing because I think you hit it. It's $50,000 for esketamine for Spravato. What's the generic version of ketamine cost? Like a couple $100?
Probably $20. The cost on ketamine is the staffing. So therapist, medical provider, clinic. The actual drug is generic in pennies.
So we're talking $3,500, roughly 6 weeks of treatment, because that's about what I typically see, as opposed to $50,000 for. And I've seen the studies on Spravato, very ineffective. I think you said 40% absorption rate, but because we got it through the efficacy of the FDA, like we're promoting this thing, and the healing map surveys I've seen, doctors don't even like prescribing it because it doesn't work, but they do it because it's covered by insurance. So it really is a perverse game all the way around. I mean, agree.
Yeah.
So I think from an employer's perspective, they just need to be a little bit more, as you said, Emil, forward thinking and start asking the questions. If I'm willing to have Cayman Islands show up at my doorstep, maybe I need to think differently about how I'm acquiring my mental health prescriptions as well, and maybe think about some out of the box scenarios.
Yeah, I mean, I want employers and payers to share in our frustration that value is in fact not being delivered and can be done. This can be done today. We should not need to go to the extent of medical tourism to support our members in valuable care. And it's unfortunate that we have to do that. But I also encourage employers, and we're talking about ketamine on this podcast, but I would encourage employers, look, I there's a pharma company that's working on a psilocybin analog for depression. And I think they're heading into phase 3 clinical trials, I believe. And that's incredibly exciting. That's encouraging. But I think, there's also, in my mind, if employers are today like you mentioned, Alan, employers are already opening up to the idea of things like medical tourism to the Cayman Islands just to get Humira, right? And I think about what the future looks like for the psychedelic assisted psychotherapy framework at large. And I think about what's happening in states like Oregon, what's rolling out in Colorado, what's on the ballot in Massachusetts.
Yeah.
And I implore those that are out there in the employer space and the benefit space, if you are curious, reach out to us. We're happy to educate you. Or if you're an ally, ask yourself that question. Like, what, if we can send employees to places like Oregon, where the state of Oregon, right, the Department of Health and Human Services has created structure around plant-based psilocybin therapy, and you're thinking about the pharma model that's coming down the pipeline and the costs that are going to be incurred in it, the games that are going to be played there. Ask yourself, do you want to, if you're going to implement, if you believe in the outcomes, the efficacy, and the durability for psychedelic medicine, are you going to be the one that focus on value? Are you going to be the one that's willing to say, I'm going to implement medical tourism for psychedelic assisted psychotherapy? Because I think any way you cut it, unless we make some meaningful change in the structure and the ecosystem of healthcare, I think that might be a really worthwhile option.
I think that's actually a brilliant idea because we've seen it in so many other things that you can just write into a plan document to be able to say, we're going to cover the cost of travel. We see it a lot with centers of excellence. So if you're going to have a liver transplant or somewhere else, the networks have literally created these centers of excellence where you put into the wording of the document, we cover travel, we cover transportation, we cover all meals, everything else for you and a +1 and whoever your donor recipient is. We have the knowledge. I mean, we're doing it today for somewhere of 23 really horrible transplant conditions. I mean, it doesn't seem like it would be that difficult. But again, I think it just goes back to educating these employers. Something that you keep referring to the return or the value. And that made me think back in the early wellness days, earlier in my career, we were trying to explain to the broker and to the employer community that you can't put a return on investment. I can manipulate those numbers all day long. I mean, I can make anyone who asks you for an ROI, I feel like I almost feel like Chris Farley and Tommy Boy. If you want to guarantee in a box, I have spare time. But the value on the investment, right? What am I actually getting for the investment? So what are the numbers? What's the cost? And then all of the things that go around that instead of just focusing on the return like we love to do in the benefit space. Consultants love to talk about the return, which again, you can make a return anything. I can manipulate any number you want.
You know what my hot take is there? I think that narrative, that lexicon on return on investment is driven out of fear. It's driven out of fear because we've invested so many dollars into healthcare, into mental health care, and people on the margin are like, this isn't working, right? It's not working for me. I want something else. I want something different. Utilization runs low. And so if I'm a CFO or I'm a leader, I'm a benefits expert representing an organization, I'm operating out of fear. I'm like, you need to show me the numbers, show me the math, prove to me that this, X, Y, and Z are gonna get hit. Prove to me that there's a guaranteed savings model. And we're so early at this, and the amount of kind of wand waving that exists in the space on when it comes to savings guarantees. If you are committing to savings guarantees, I mean, I feel like you probably haven't looked at a claim set ever, right? And so, I encourage, when I think about doing this with integrity, I think look, at the end of the day, step one is utilization on the benefit and outcomes, right? If you can prove that more people want to use this service because they are frustrated with what's historically been available, or they're curious to try something new. And then if you can show that the outcomes of those individuals is best in class, step one. Step two is you can show that those outcomes are not only best in class, but they're durable and they last a long time. Step three is for those individuals in a vacuum, can you show that best-in-class outcomes that are durable actually drives other mental health service utilization down so you can mitigate costs? And then the pie in the sky that honestly no one's figured out but I think on the margin, the three of us on this call believe in, which is like, if you can show that there's high durable outcomes and other ancillary mental health utilization trends down, you can in fact deprescribe mental health medications, and then you can go over on the physical health side. And on the margin, you have to be operating under the belief that if people are mentally healthy and well, that physically they're going to want to take care of themselves better, and they're going to treat themselves better. And that's the pie in the sky. That's the self-actualization of Maslow's hierarchy of needs. That's the end state. And I think the only way to get there is a very intentional, deliberate path of data measurement to validate and to show and to build in public and show the space that like this is the only way that you can prove out that this isn't just another kind of like middleman capture. Like, hey, we want to wedge in psychedelic medicine, get people on it, get them on it every 2 weeks like Spravato in perpetuity. The goal here, and we started the conversation with this, but around intention setting, deliberate psychedelic assisted psychotherapy session with integration. So people are really learning about themselves, about their ailments, and really building this kind of foundational structure that they can live a very high quality, healthy life that includes physical health. That's the pie in the sky. And it's going to take time and intentionality to get there. That's, if you really want to disrupt healthcare and you're not a psychedelic ally, you really want to disrupt healthcare, it all starts with this, right? People's behaviors, their habits, it all starts with what we today consider in our lexicon mental health. And that's why I just think it's such an exciting opportunity. We just got to do a ton of intentional work to get there.
And I think that's really why I wanted to create this show, because I think our Western culture, immediately as you're saying this, I'm thinking two camps. I'm thinking of someone like us who we see it, like we live it, like again, 10 years of therapy in 3.5 hours. And I don't have any of the other, what we would call indirect costs of healthcare. Bessel van der Kolk said it best: when the body is at war with itself, you have all these other conditions that are going to show up as chronic conditions, which is why we call it dis-ease. But in our Western thought process, we don't think about that. And there's the other side. Oh, that's just woo-woo. So, but until we can get woo-woo and science to agree, I think that the pie in the sky is going to have to just require a lot more soapboxing and a lot more education from people like us.
We're going to do it. We're going to do it. I want to implore every health plan exec, every self-funded exec out there. Remember, like my wife is operating she was just on a fully insured, moved to self-funded plan. And she was telling me before, I was traveling up to Tahoe, and she's traveling before I went up. She's like, "Oh, I'm going to my acupuncture visit." I was like, "Wait, I'm just thinking about all of this stuff that we're doing." She's like, "Yeah, I'm going to go see my acupuncturist." I was like, "How? Is there a copay?" She's like, "Yeah, there's a $20 copay. The rest is covered by insurance." And I was like, and then it's just like I looked at her and she looked at me, and I was like, "Oh, we're going to make this happen." Like,
absolutely. As you're saying that, I remember like 20 years ago, we were like, they're quacks. Like, we're not covering that. And then it was like there was a network of complementary healthcare providers that really weren't healthcare providers, because we just, like our way of thinking is just so crazy.
We're slow at change. Change is scary. That's okay.
Well, the other problem too, that from a benefits perspective, that a lot of people don't realize too, is that everything that we do in the US with a healthcare system is around an ICD-10. So we look at diagnosis codes and we apply a procedure code to those. So the system looks at those. But what many people don't realize is that the ICD-10 was actually created by epidemiologists. They wanted to track diseases amongst populations. We are the only country of all of the adopters of ICD who monetize it. So if you think back to when ICD-9s were actually being phased out by the WHO, World Health Organization, and 10 was coming in, we were 13 years after everyone else because it took us that long to monetize the next decimal. So everything that we do here in healthcare has a monetization component of it, which, going back to these 230 different clinical trials of psychedelic drugs right now, it is going to be an interesting thing to watch, because they could go to Massachusetts if they vote yes. They could go to Oregon. They could go to Colorado, but they're going to ultimately end up spending 4, 5, 6 times in a healthcare plan because we didn't ask the right questions.
And I think, look, I think and healthcare and business, the intersection of the two is like, woof. But I think at the end of the day, we should all consider healthcare as a service, right? Like right now, it's a service. We want to provide that service, and if you're going to pay for it, if you're a health plan, if you're a payer, if you're a self-funded employer, you're going to pay for this service. You just want to focus on value, and so you want to get down to the nitty gritty N=1 details of like when people go through this experience, how do they feel, and what is their impact on their life? And then make sure whoever you decide to work with is able to bring the receipts on the durability. Because I think if we're going to talk about mental health, and we're talking about this generational shift that we believe is going to occur in mental health care, which is more like root cause versus symptomatic treatment. If you want to get to root cause, is anyone throwing around the vernacular root cause if they're also associating that with a daily treatment or a weekly treatment or a monthly treatment? Ask yourself, what does it mean if we're actually going to implement root cause treatment? Sure, there might be a cost associated with it, but focus on the efficacy and the durability over time. I think that should be your North Star.
Agree, because if you're just looking at cost, I mean, we know one thing's for sure. I mean, you said it with Spravato, that's every 2 weeks for life. So getting to a root cause ultimately means you're getting to the exposure of the root to be able to actually heal, to not have to continue to do the things. So from an employer's perspective, again, a 40 to 50% of my claims are going to be RX claims in the next 5 years. Why wouldn't I want to look at another alternative that's going to lower my spend? Which is why, again, we see a lot of companies looking at medical tourism. So ultimately, if you're going to spend it for life, you might as well do it for 70% less.
100%. You know, I was chatting with a friend internally here, and we were talking about like how, you know, all the breadcrumbs exist to show Spravato, the other psychedelic medications that are in the FDA approval pipeline. You know, you look at the TAM on these medications, look at the numbers, right? The millions of people that have an indication of depression. These are the next GLP-1s, right? Like you can tell the future here. It is laid out in front of you. So again, it's like, what can we do to put pressure on the system to say, hey, do we in fact want to cover GLP-1s in perpetuity, or do we want to pair GLP-1s with behavioral lifestyle modifications so that people can taper off of GLP-1s and be the healthiest versions of themselves? Apply that same logic and learnings ahead of time proactively to how you want to manage the mental health of your population.
Wow. That's a really good framework because, again, like you're saying, I mean, we're already there. Like for the last 2 years, we've really been implementing a lot of these changes in employers. And if you would have asked, I think, an employer 3 years ago, GLP-1s even existed or how it all worked, no. So we know we have the capacity to be able to do this on the fly if we thought it was important.
Exactly.
So what's next for Meeko? Like, where are we at right now? And what can an employer do?
Right now we're taking care of, we're taking care of customers that we're servicing throughout the United States. We're working with them on education and awareness to increase utilization so that we can continue to showcase the incredible outcomes and results and the positive impact that ketamine therapy is having on people's lives. Ketamine therapy is the only FDA-approved psychedelic therapy that exists today. It's the only one we're working with. As other compounds get approved by the FDA, we'll add them to our repertoire and provider network. We're also focused on education and awareness to self-funded plans, to HR leaders. We really want to advocate for innovative mental health care. What does the future look like? And how does really thinking about forward-thinking mental health solutions like ketamine-assisted therapy, why should it matter? Beyond cost savings for HR leaders, why should it matter? What is the next step, right? And I think the interesting thing that I've seen firsthand over the last year of doing this is really when you think about you think about mental health as an employer, as an organization, and like what you're really trying to do is you're trying to create a culture at an organization that centers around holding like holding your employees, holding human dignity high, holding agency high, holding psychological safety high in high regard, allowing individuals to express their creativity without fear of recommendation, right? Allowing people to do their best work of their lives, allowing people to come to work with a deep sense of purpose, right? Allowing people to just flourish. Because if your people are flourishing, your organization's going to flourish. And kind of this is the world that we're living right now. We're living in this world right now where we're trying to figure out, like, we're constantly trying to innovate. We're constantly trying to kind of adapt to this new world. We're still trying to figure out the impact of COVID, right? Are we working in office? Are we not? Amazon's bringing everyone back into the office, right? And these make big social impacts on how we feel and how we can show up and work with purpose, work productively. And so we're out there right now focusing on educating up market and focusing on really that like core value that every company has in common across the United States. It's like we want to create a culture of excellence. And how do you do that? We can't do that if you're not truly addressing mental health. And so we're questioning, like, are we thinking about all the innovative ways to address mental health, and what are the hidden areas that have such high value that we might not have considered? Excuse me. And that's where we're educating about ketamine assisted therapy.
So for a benefits broker, consultant, because they're essential to the equation, are they open? Are they receptive? What has been some of the feedback?
Receptive. I think they want to know. They want to understand what the space looks like. They want to understand the use case. They want to understand the details of what does a provider network look like? What are the indications for ketamine therapy? They want to understand and they want to be comfortable in knowing that there are clinical studies that support the use case of ketamine therapy off-label for these mental health indications. And kind of going deep on how are providers vetted? How do we make sure that this is very safe to bring to the table for their clients? And I think at the end of the day, a lot of this comes down to integrity, right? If you are a consultant, if you're a broker and you want to bring something to your client, you want to make sure that it is integrity with your values, that there's trust there. And so I think a lot of these channel partners, these brokers and consultants they want to learn, they want to deeply understand, what is this? And how can I bring it to a client, and how can I show the client themselves that this is a use case for you and here's why? And I think, on the margin, as we're having these conversations with brokers and consultants, they're all just like blown away, right? Because I think when you get into the weeds and you start to educate them on things like brand name Spravato versus generic ketamine, I think their eyes light up, because they want to be the ones to deliver value to their customers. And so, like, we're serving it to you on a platter. Let's educate you so you can then take it to your customers and educate them and show them why this is a perfect use case for the issues that your customers are facing.
And I think it's a really good time too right now, because I was just kind of looking at some numbers. I think if you kind of look at, and this was just, I think 3 days ago, Mercer just acquired McGriff Consulting. So the goes it's like this now. So of actually how many agencies there are. And I remember when I started in this business 30 years ago, you could throw a rock and hit a broker. But there's so much consolidation right now, and every one of them have their own centers of excellence, and they have their own consultants who do this and do that. But they're still largely uninformed about things that matter, like this. I think they're so used to being, just as we said before, part of the machine and the system, good, bad, or indifferent. I'm not indicting brokers. It's just, that's what it is. It was almost the same conversation. We would sit down with an employer and say, you're spending all this money on these brand name drugs. If we just make this one small shift, I can save you $500,000, or in all you're doing is changing the location of where you're getting it. And the broker community was just like, wow, you have no idea. So the education, I think you're right, is just so important for them. So, and say, how about HR and CFOs? Because I've always looked at it's always been a really odd kind of mix for me, because HR hates change. They will do whatever. My wife was in HR for most of her career. They wear 5,000 hats. They're overworked. They're underpaid. And then you want to throw this other thing in. So it's got to be easy for them to understand. CFOs, I think you hit it. They're risk averse. The only thing I think a CFO cares about truly is their job, because the CEO or the board is hiring them to protect the asset. So they're going to constantly live in that scarcity fear mindset. So instead of like looking at the value and what the actual reduction would be, as you'd said,
Mm-hmm.
we need to get them to think differently about these scenarios and these situations that they're putting themselves into.
My hot take is I want CFOs to continue to do exactly what they're doing, because like I want them to be scared about losing their job. That's what I want them to do. And I think if we're doing our job, then it should just be like water acts like water, because it means that we have nailed the narrative in educating CFOs on, if we're doing our job correctly, a CFO should be able to look at our playbook and look at our value proposition and say, like, where do we sign up? Right? Because I think on the margin, what it tells us is it allows us a goalpost to work backwards from, which is we need to be able to educate the CFOs of organizations that if we've already won over HR and we're getting to the exec team, we're trying to push through the CFO, then it means that we really have brought the receipts, not just a compelling narrative, but brought the receipts on value. And that's why, the 5 steps that I laid out earlier it's so important that we're focused on those outcomes, the durability of those outcomes, and then how do those durable outcomes actually impact and move the needle on spend, both for mental health through decreased utilization and on overall medical plan costs. And am I able to say, Alan, we're having these CFO conversations today, we are crushing it? Absolutely not. I'm saying it's difficult, but it means that if we can do those 5 things over time, that's the hard work. That's like, it should not be easy, but you have to do that with intentionality and be very deliberate about it, because if you can do that, then I think you've built a moat that just like is very strong, and it helps kind of shift. It's a paradigm shift, right? It helps move the needle at scale then for why employers want to implement psychedelic assisted psychotherapy.
See, and it's always been in my experience, I never really liked working directly with HR or CFOs. I just didn't. I always really, if I could, I would work directly with the CEO, because it's the CEO's name who's on the door. It's his name on the building. It's his vision that created the company. And normally, like if you got to that person and you understood what their vision was, oftentimes it aligns with exactly what you're doing, what you're thinking, because he wants his people to be there 100% every day. He wants them believing in the vision and moving the needle forward as a company. But it's these other impediments that are like 3 levels down that really don't have that vision.
I think you just nailed the reality of the world that we're living in right now. So the way we kind of qualify our processes right from the top, we try and go straight to the founder or CEO of an organization. Are they a psychedelic ally? If they're a psychedelic ally, we have strong conviction that we can go in, and we've done this in the past. We can go in, build a relationship directly with that CEO, who's the ultimate decision maker. And if they're a psychedelic ally, they believe in the vision. They believe that we can implement it now. They understand that we're doing it appropriately with the right kind of rails in place, safety. We can get them on board, right? And we can do that. However, I'd say that unfortunately today, in today's world, most CEOs are I would say they're psychedelic curious. They're not anti-psychedelics. They're not psychedelic allies. They're psychedelic curious. So it's like they're gonna need breadcrumbs of education and information, and they're so busy that if you're going to talk to them about health benefits, they're going to say, you need to talk to my HR benefits leader, right? And so that's just the reality of the world that we live in. But I would say to your audience, my public service announcement is, if you are a leader of an organization, big or small, and you believe in the future impact of psychedelic assisted psychotherapy, and starting today with what we have available and the impact and outcomes it's delivering to human beings, then I implore you and I encourage you, please get in touch with us. Because if you're an ally, we want to work with other psychedelic allies out there that can move the needle and make decisions. Because number one, I don't think we have time to sit around. And number two, we encourage everyone that is an ally to please take radical responsibility in helping us shift the social narrative around what we believe the mental health care future can look like. That's my PSA. That's my plug.
Wow. And that actually is a really good stopping point, because I agree. I think that one of the biggest things that I learned coming back from my experience was to be able to be open and vulnerable with my employees, to be able to know that it was okay that I didn't have the answers, which is, again, that's why I think a lot of employers, when they come back from an experience, they end up leaving the organizations that they start, because there's something different. But what I found is that when I came back, I started a podcast called The Cost of Doing Nothing. And my employees listened to my podcast. And I shared everything. I shared my good, my bad. I shared my stories of abuse. I mean, there was nothing off the table. But what I found was that my employees appreciated me more because they saw who I was, not as the person whose name was on the door, but as the person who was there every day, who was human. And I think that that's the tendency that we have as leaders sometimes, is that we feel like we have to be almost this fatherly figure that is carrying all of this weight, and all the employees really want to see is who you really are. And I think if they can see who you really are as a leader, whether you're psychedelic ally or curious, if you were to ask yourself as that leader, is this the best I can do for my employees in any situation? I think it's going to play itself out. And I think we're going to have this conversation, and I think it's going to be further along, much faster than it is today. How do we get a hold of you? How do we find you?
You can reach us online at meekohealth.com. You can also reach out to either Nick or I at Amil, or Nick at meekohealth.com. And you can also find us on our LinkedIn page.
And I'll put everything in the show notes, and I will put everything on LinkedIn as well. So thank you both, not only for your friendship. It's been a great several months together, just kind of getting to know you guys, kind of seeing what you guys are doing, and
Likewise, Alan.
love watching you guys grow. And I think maybe we should do a round two, maybe more of a webinar for employers. So
sounds incredible. We would love to.
Awesome. That's Alan Wiederhold. Thank you very much. That's Neuma, the crossroad of science and enlightenment.